What I'm going to reflect on is, for the talk in the next 25 minutes or so, I was asked to cover sort of more of the mental health, psychological, cognitive health, and HIV and aging. And so, and as Scott pointed out, so I'm a researcher, but I'm also a scientist and a clinician at the hospital, it's downtown hospital, St. Michael's Hospital. We serve the inner city of Toronto, very vulnerable people. HIV is a priority there. It's a great place to work, been there for 20 years. But I also run for the province, the research policy organization. So I'm involved in, and you'll see this reflected in my talk, and it was great listening today. I couldn't be here yesterday, but listening today about the issues around aging and mental health and depression, social isolation. So I'm going to really pick up on a lot of the comments that have been made through the talks. It really does resonate, the things that I'm going to sort of emphasize that I think are important in sort of my review of the area and the context in which I work, which is really to find solutions for the people living with HIV in Ontario. And let's see if my thing works here. So pushing forward, it's not moving. So they told me that it was working, but am I going to have to, you're going to have to do this for me, or was it going to work? Sorry? Maybe you can come and take it. Okay. Try it. So anyway, lifestyle changes, adaptations with age. I like this slide because, you know, I just turned 50 this year, and I'm paying attention to myself a lot more, sort of my own health. But this is sort of a context that we're all sort of feeling as we all get older. No caffeine, no sugar, no wine, no cheese, and by the way, stay out of the sun. Okay, this is my agenda. Oh, there was my agenda. Oh, there we go. Okay, so I'm going to cover these 10 things. I'm going to situate this work actually in the cascade because I think it's a really good framework. I'm going to tell you a little bit about what's happening in Ontario, talk a bit about a framework for successful aging, which you guys are the experts in, but I'll just going to highlight because it helped me ground how I'm going to talk about things. We've done some work and reviews on HIV and aging. I'm going to share with those with you and some of the highlights and really focus on 5, 6, and 7 in my talk. So I'm going to weave through that. At the end, talk about some interventions. Those 5, 6, and 7, I'm going to highlight some of the issues and really looked at the data that we have in Ontario to really hit home how these things are interconnected. And so I'll share with you those findings, which I think does resonate with a lot of the discussion and the issues that were brought up today.
So if you point it to the back,
okay.
Put it behind, don't keep it behind the
Okay, great. So that's what I'm going to do. And everybody knows about 90-90-90. We have a health minister, Dr. Jane Philpott, who was at the IS in July, was very active. She's a primary care doc from north of Toronto. We're going to be releasing our targets or how we're doing on the cascade December 1st on World AIDS Day. And Ontario is going to get a little bit ahead of those numbers because we don't want to get caught up in what's happening nationally because we're actually doing very well. But this provides a really good context, and I think I'm really happy that we have a federal health minister that's taking this issue so so focused and wants to do something about it. And that's why she got into politics, actually, because of her work with people living with HIV. And everybody knows this, that it's amazing research effort, science that is, in terms of longevity and people living longer, almost nearly as much as people without HIV. But I think the real important gap now is dealing with the other stuff. And that's really a lot of the focus today on talking about not only just the medical findings, but the lifestyle and the life issues that are important. So we're responsible for monitoring the epidemic in Ontario. This is part of my job. And just to show you how we're doing, or what the status is. So in Ontario, last year there was 842 people that were infected with HIV, or diagnosed, I should say, with HIV. About 60% of those infections happen in Toronto. So that gives you a sense of the numbers. So about 1 out of 6 people that are infected with HIV in Canada are infected in Toronto. It's an epicenter for us. The cascade, as you know, here's our cascade, and the bars on the left are sort of in hash because we're actually doing modeling to get at the fraction of undiagnosed. It was previously higher than we thought it should be. It's probably around 18% now, but so that's the target zone, but that's how we're doing overall in the province when you look at everyone depending on those targets. But then you really look at people who are actually in care. So there's about 16,000 people with HIV in care in Ontario right now, and you'll see that changes obviously happen because of guidelines, but going from 40% suppression rates to 80% is actually pretty good. So we're doing a good job, but it's really now getting the people that really fall through the cracks. And just to highlight, it is the mental health, it is the social issues. And syndemics, I didn't hear that word today when I was listening, but it's something we talk a lot about in terms of risk for HIV. So what got people HIV in the first place? The things that happen very early in life, abuse and mental health issues and drug use and all those things that happen because of complex issues that people who are vulnerable experience and what those do to carry risk for HIV risk and other risks. So you see here that in continuous care or being suppressed, how you have more of these factors you don't do as well. And so these are the issues that we are prioritizing in Ontario and Toronto in particular on how we develop interventions to address them. So we have this large cohort study going on that's following people, and so I'm going to be drawing from that today to show you some data on these issues around mental health and psychological well-being. But they come from various cities here. This is sort of a picture of Ontario. First of all, Canada's a big place. Ontario's a big place too. And you'll see at the bottom left is Windsor, Ottawa is to your right, and Toronto's right in the middle there. But just to highlight now, start to give you some data. This is population data now from the ministry, because we have administrative codes within billing codes for physicians. So depression rates of 28%, recurrence of 51%, and incidence of 17%. So these are actually, and these I think are underestimated numbers in terms of these are sort of billing codes. There's obviously a lot more people that have depression that probably don't get recognized in the first place. But it gives you some context for. And I saw some similar numbers today in some presentations. Whoops, whoa, I don't know what happened there. So the second slide, sorry. I was looking just at the delivery gaps in mental health care, primary and secondary mental health services. So those are diagnosed, only 50% have access, antidepressant, 39%, and minimally adequate mental health care at 50%. So you can see that there's people get diagnosed, there's still barriers. It's another cascade, so to speak, of access. Clearly people who have depression, substance use, or both have 30 to 50, 90% higher rates of emergency use. And this is in a city where, again, we have a socialized medical system. So these are gaps that happen because of the hospital clinics and primary care and community-based care and how there aren't linkages to help support people. And so this is a lot of what we're trying to address. We have very good administrative data in Ontario, and this is just a slide to highlight that we're tracking that and looking at men and women in terms of their morbidity and knowing about men and women and the different access points. So it's something that is very helpful for have that one large system to be able to track. And so that's sort of to give you a context of the people, the sort of the work that I'm doing in Ontario and the context for some of my comments about what we're trying to do. And then now I'm getting into sort of just in a brief way, thinking about how to think about aging. And the successful aging model, I'm sure you're all familiar with, but it's really about looking at these different dimensions and the intersections of those, and clearly how can we collect data or have research data that can help inform better practice and systems. Dilip Jesti in San Diego has done some nice work looking at this the sort of successful aging. And interestingly, this is now a few years old now, but the number of definitions and how it's conceptualized. But you can see the correlates with successful aging, those sort of age, those being around 60 compared to others, non-smoking, absence of disability, arthritis, and diabetes. The moderate correlates, and then where sort of demographics are not related. So there's really nice work going on, really trying to frame how to think about this area and how to think about the kind of different parameters and variables that we need to be paying attention to. He's obviously done some more work. I'm just really highlighting that. I'm going to focus more on, enhancing successful aging, it really does include looking at more of the softer stuff, the social support, cognitive stimulation, and how you manage stress. Some nice work going on, and really these are just backdrops of, so what we did was, in terms of our framing of this, and I'll show you in a minute our review, is just to get a sense for what's out there in the literature, what are people talking about, and clearly people are moving to a place of going beyond the medical parameters, the hard to the softer stuff, to understanding the context for people's lives and the complexity of those lives. Here's a review that we published last year, looking at an array of sort of areas of topics in HIV and aging. Again, I'm going to focus on those three areas of cognitive functioning, mental health, and psychological well-being. But just to give you a sense of the 209 studies, in that particular area, about a third of them were an area that I'm going to talk about. So that gives you a bit of context. And for this meeting, because it was a few years old, we did another review just to update that to see where we were. And there were 52 studies, primary studies, and we took a higher bar. Those were more data-driven, had sample sizes of greater than 200, and to look to see, what's been happening since the last review that we did. And here how it breaks down in those three areas, so cognitive functioning, mental health, and psychological well-being, and where that work is happening. It's principally 95% of it is in the US, but you can see some emerging work in Canada, and then other. So these are Australia and the UK, I believe. So this is a body of work that's just starting to get off the ground, and we really need to think, and these meetings like this really help to emphasize the importance of really promoting and advocating for more work in these areas. And just to contextualize now, as I talk about going more data-driven and looking at what we're finding, the Cohort Study is one that I've been involved in. I'm the PI for in the province. It's been running since '95. And you can see at the bottom there was over 6,600 people that ever enrolled. Currently, there's about 4,500 people that are currently active in this. And so these are people that are seen within, these are people in the clinics. And my agency helps to support the 10 major clinics that are in the province. And some of the data I'm going to talk about relate to depression, mastery, quality of life, social support, and cognitive functioning, which are collected principally in Toronto. And just to give you an idea of the sample, so you can see there, the data I'm going to present is on over about 1,100 people, with total person years of over 3,000. So this is a group of people being followed serially over time. But you can see there the age range, and we still have a cohort of people that are being followed. You can see the 22% that are in their 50s, 5% in their 60s, and 65 plus 3%. So it's obviously an aging cohort. We have principally a group, the infection rates for HIV in Ontario, MSM is a major category, and you'll see the breakdown for race and ethnicity. We do have people from Indigenous, Aboriginal communities, and African, Caribbean, and Black. You see there at 29%. So those are just some sort of parameters to think about as we talk about, or as I show you some of the slides on the data, the sample that the people that are receiving medical care in Ontario, and who we're seeing about 1 out of 4 of those people who are actually in a clinic. You see on the right the morbidity factors. So first, looking at cognitive changes. And so I think people are very familiar with the work going on around the prevalence of cognitive impairment. There's sort of a range of rates. I'm going to show you some of our data in a moment. The cognitive disorders that occur, but despite combination therapy, HAND still persists. And really, that is probably changing as we look at people starting earlier on treatment and what that might do to minimize the rates of the development of cognitive impairment. As you know, HIV, in terms of presentation, can cause a variety of cognitive concerns in these areas. It tends to be more what we refer to as subcortical, sort of learning efficiency, recall, speed of processing, working memory, executive and motor skills. And this tends to be fairly spotty, so that one person presents with some of those and another with another set, and not everybody always has all of those. And that's been fairly consistent, although we may be seeing some changes over time now in the current CART area that some centers are reporting on. If I can get this to move. So I think everybody's familiar with HAND, the 3 different categories, but just to highlight asymptomatic neurocognitive impairment, mild neurocognitive disorder, and dementia. And so those 3. Okay, here's some work out of, too fast, out of San Diego. Now sort of looking at rates, and Bob Heaton and Igor Grant have published a paper looking at accelerated aging and cognitive functioning in positive people. You can see the difference in rates or the declines. What's really interesting happening is that with this large data set from Max now starting to look at trajectories, I think this is going to be a really important area of understanding, who's stable, who's progressing, who's improving, and about 2/3 of people remain relatively stable once they develop mild HAND. The other third are improving or worsening. What's happening? Is it comorbidities? Is it mental health issues? I think that's something that we need to really get a better handle on. And I think the MATS data set will really help us understand more of these trajectories because of the larger data sets for longer periods of time, and really understand some of those predictors for those. So be really interesting to see as this work evolves. Here's what we see in Canada, and this is very similar to what you see at the HNRC and other centers around the world, where we see about half the people, or 55%, have cognitive impairment, and you can see there about 1 of the 6 people are diagnosed with MND, a very small number with dementia, and then a large number of people in this asymptomatic category, which again is being studied in terms of understanding what that really means to progression. To symptomatic HAND. What I wanted to highlight is for the last 25 years, there's been a lot of work that's looking at the cognitive impairments from a objective standpoint. There's very few studies that have gone actually asking patients about what their experience is. So I had this physio that came to see me, worked with, and she got some students together, and we published a couple of papers. Now we're doing a number of studies, really trying to understand the context for how people are managing. If you look at the brain injury literature, and I talk about HIV being an acquired brain injury to my patients that I see, because it's something that happened along the way, and I think we don't really have a good handle on how people are managing that, and I think that needs to be much better understood. So it's great to see that we're doing that. There's some folks that are doing this, and I know some other centers that are starting to do that. That's underway. And now in terms of aging, so if we look at our sample and we follow them, we're seeing that the increased rates of impairment when people get into their 60s and 70s. So the rates of about 50% go up to 60 to 68%. Now, we don't really know exactly what's causing that yet. We're doing analyses, but it's just to show you this is sort of hot off the press. And you can see there that the person years that contribute to those latter categories, are those comorbidities? Are those, what's going on there is still something that we need to tease out. It's something that's new for us in terms of the studying these people in our cohort. And just to highlight that, all of us peak when we're 20, and this is data from the waist. But if you look at these next 2 slides, looking at speed and working memory or multitasking, that we're really good at it when we're young, but all of these things change as we get older, and these are pretty steep curves. What we think happens with HIV, obviously, is there's sort of a steeper decline, but this is still something that needs a lot more work to tease out, and it really has very significant implications for everyday functioning. With slowing down is one thing, but if you can't really multitask and you're having difficulty with those things, can you stay at work or not? And so we need to do much more than just study the rates of these things, but understand what's going on at what point, and what can we do to stop those processes or make them better or help people compensate. And there's not a lot happening on the help side of those issues. Here's focusing on a group of 200 men who have sex with men, and looking at, there's controversy about whether, again, depending on populations, we're seeing that slightly higher rates of men who have sex with men when they're older have increased risks of impairments on the right. And you can see there the slightly higher rates cognitive impairment and diagnosis of hand. We heard some talks this morning or this afternoon around the VAX index, and we're looking at that in terms of as a marker to help us understand the complexity of morbidity. I just wanted to highlight that this work is underway in our center, but also you can see there that depression is a predictor, a univariate, but not in the multivariate model, but cognitive complaints is in the multivariate. So there's something about, not in addition to the diabetes and other things that, and San Diego, the UCSD group is doing some nice work in this area as well, but really teasing out what are the other things that are involved in sort of understanding those trajectories. And we just replicated a paper that the UCSD group did, looking at people who had high and low VAX index, and people who were normal to begin with neurocognitively and following them over time, and showing that those with high VAX index was predicted of developing incident neurocognitive impairment. So there's something that we can tap into that helps to track these things, and I think it's helpful work that will help clinical care. This is some of David Moore's work, looking at just if you see on the graph there, looking at younger and older HIV-positive, HIV-negative folks, and looking at the performance-based neurocognitive deficits and self-report symptoms, showing changes as with aging, so more so than in controls. So these are things, obviously, that people are struggling with, and it isn't only the sort of the symptoms, but the impairments, and both of those together really lead to reduced quality of life for our patients. A few last slides in terms of the cognitive impairments, look at some of these predictors before we get into more of the mental health and psychological well-being. But just to show you in our sample in the middle and the MSM, because we have such a large sample of men that we're following, and looking at the different predictors and seeing how the age, the demographics, obviously the complexity of addiction, smoking, diabetes, but cognitive symptoms. And here's where it starts to get interesting that we've never looked at before, starting to take some of those psychological variables, in this case mastery, and showing how mastery, and this is about persons sort of, their resilience, their self-efficacy, their ability to sort of manage under stressful sort of conditions, and looking at the probability of neurocognitive impairment. So there's something about this, and I'm not sure anybody's ever looked at cognitive impairment and mastery, but there's something there. And I'll show you this in relation to some of the other psychological phenomena. But really here, the probability of cognitive impairment is sort of mediated or moderated by sort of person's mastery across these age ranges, and something that we're going to explore more. And it was even more significant in our group of men who have sex with men. So again, something for just to let you know that we're looking at this and we're going to explore more. The other thing that I heard today too is just about social isolation and what impact that has. Clearly, I do work in the province on housing. Housing is such an important variable for HIV, but also the isolation that happens as we're following people, understanding we have a medical care system, but people have so little money that they don't have access to get the things that they need on the social side. And this is just to show you here how there's some relationship between a person's living situation and the risk of cognitive impairment. So that is in a nutshell, in my very quick overview of cognitive impairment, what we're learning and what we're thinking about in terms of the intersection between not just the biological, but starting to think about the psychological well-being variables. And now going into depression, and I'm just going to show you, sort of highlight these different things here and show you some of the data that we have. We know that depression is very high, and I'm just going to go over to highlight. So what's really interesting in our review, could see that there are a number of research groups now trying to understand resilience and the components, the constructs of that. What is it that, this is not my area, but if you look at it, there's a number of dimensions that I think are going to be really important to tap into to think about how these are related to quality of life, and that work is going to really help inform interventions. We're showing changes in also what's really interesting in terms of depression is that it gets lower as people get older, and we're seeing this in relation to stigma as well. Just a matter of time, I'm just going to skip over a few of these here. The other thing in terms of the protective factors that people are looking at is just those, what are those psychological resources that help to buffer? And there's quite a bit happening in the literature now, and how we can sort of pull that into the aging areas in terms of how it connects to think about what are some of the interventions that we might be wanting to try. But here's in our cohort, as I say, this large group of people are being followed, and you can see how depression rates go from 40%, and they change significantly as people get older. And this is something that's seen in the general population as well. The predictors of that, again, I'm going to show you here in these slides. So, and these psychological variables are really do sort of overlap with one another. But you see these big changes with mastery and rate, probability of depression going from 70% to 10%, depending on how somebody fills out a questionnaire for mastery. And obviously that changes as people get older, but there's something there about just that resilience and the other things, the buffers that people have, that they carry through. It really highlights too, we can't wait till these problems happen in aging. We need to start dealing with them really much earlier in people's lives in their 40s and 50s, not wait until they're in their 60s and 70s. And you can see here it's even more accentuated in our MSM group. But you see the same sort of pattern across the next 5 constructs. Social isolation, see this really marked change and difference between when somebody lives alone or with family. You look at social support, you see again this gradient, huge, 70% on the left versus 17% in terms of risk for depression and how that changes over the course of people's age. Here again, looking at stress. So, we collect measures of stress and financial stress, and again, huge gradients in terms of the burden that people are experiencing and what impact that has in relationship to depression. Belonging in the neighborhood. So, belonging in the neighborhood and your sense of community has an important dimension in terms of how it relates to sort of your mood and your overall level of comfort. And there's some really nice work that Tim Heckman is doing with supportive therapy and coping studies and RCTs that have been published in the literature that really try to get and reach people in terms of social isolation, social support. So there's really nice stuff that's happening in the aging literature. The last area is just the psychological well-being. Just a few slides here looking at the same things are mirrored when you look at measures of quality of life that are the reverse to depression. So you can see how it goes up as people get older. And looking at the predictors, again, mastery and all these other things have the same kind of relationship. So these are, outcomes that are important to track, but also it's important to, I think, for us to look at the psychological constructs that go into why somebody's overall mental health status is getting better. So again, you'll see the same sort of trajectories that I showed you for depression. The reverse are improvements you see with mental health outcomes as people age. Here's sense of mastery. And then the last thing I'd like to say is the importance of exercise and cognitive rehabilitation or cognitive stimulation. And really the preliminary studies are very encouraging. Again, work out of UCSD with David Moore's group showing that people who exercise have half the rate of cognitive impairment than those that don't. And what's really interesting, and we've known this for some time, that people who, this physical exercise, social activity, and employment, so that's those stepwise increases. The more you have of those things, the more you do things as you get older, the less risk you have of having cognitive impairment. And this isn't rocket science, and we've probably known this for a long time, but now there's really good data. This is cross-sectional data, but I know that there's going to be work following these people to see what happens. Cognitive stimulation, again, the Mayo Clinic had a really nice study looking at aging and showing improvements for people with HIV in overall aging. David Vance, and I know the UCSD group, we've done some work in this area as well, showing that cognitive training using these programs, if done for long enough periods of time with enough intensity, has a chance to improve cognitive status. So I'm going to leave you with, and I was involved with Bruce and Scott with this clinical management of hand-mind exchange program. So I think something like this needs to really be done with aging, sort of how you look at the intersection between assessment and treatment for aging. And I think it's really helpful to be thinking about some guidelines along those areas. I'd encourage you, there's a really nice piece, A Mind of Her Own. This is a lawyer who has HIV, that I often do community talks with. It's published in a magazine called Positive Side. And she describes her experience living with HIV in hand, but she talks about the stress and the social isolation and what it, how it impacted on her life. And it really, I think the more we hear these stories, the more we can understand what we need to be doing in terms of interventions for our patients. And I'll leave you with this slide. Everyone has a lifestyle, and some are better than others, but she seems to be doing okay smoking at an older age. So the highlights really from my talk are here. I guess I really want, those are from the OHN Cohort Study, but I want to leave you these four thoughts that I really think that we need to do a much better job with identifying people early, screening and younger age, looking at who's most at risk, and be able to know how to intervene sooner. The medical system, and we're doing such a great job with HIV treatment, we need to put our efforts there. I think the guidelines are really important as well. We have our own guidelines now in Ontario, what people get once they're diagnosed, and not just the care for HIV, the other things, getting screened for depression, for isolation, housing, these sort of things. These are important things. If we don't get them early, they're going down a different path. It's those social structural drivers that we need to be looking at that are really important for the cascade. And I think the context for this is really exciting, is to look at the whole framework of sort of implementation program science, where we can think about how to look at these systems and what needs to be done across sort of clinical, medical, public health, and community. This is what we're doing in Toronto. It takes a lot of work, but I think it's the only solution that's ever going to help us see better outcomes for our patients. It's never going to be do better HIV care, better geriatric care, better this. It's how the integration is going to work. So these are some of my sort of thoughts or reflections on what we all need to be doing better, and I'll leave you with that.